what does it mean, retroperitoneal, Mr. Andy?
In the back.
In the back? You want to clarify that, Monica?
Oh, it's behind the peritoneal.
Yeah, if you remember that most of your organs in the abdomen are surrounded by the peritoneum, right? The peritoneum does not cover your kidneys. It's located behind it. So that's why they say retroperitoneal. That's why when you have bleeding and stuff in the kidneys, it kind of fills up the area around the pelvic area. And then this level of T12 to L3, this is so that when you're positioning the gamma camera, normally I think most people just put like a little radiation source over the umbilicus, and then they put that in the center of the gamma camera, and then that way they pretty much have the kidneys there. Okay, unless they forgot that the kidney had they had a transplant. That's one of your board questions. They'll always throw that in there, like where you position for a transplant patient. Now, with transplant patients are over the pelvis, anteriorly over the pelvis. Otherwise, it's posteriorly at the level of the umbilicus, and so T12 to L3 is in that area. This next question, or this next part here, the cortex, the medulla, and the hilum. This is going to be important for you. How many of you, when you're doing a renal study, you have three separate regions of interest? You have the cortex and the medulla separated? Okay. Yeah, some people just draw the whole kidney.
We do the whole thing, and then we also do the cortex.
Oh, okay. Yeah, I mean, the cortex is where the glomeruli are. That's where the filtration takes place. The medulla has the collecting system. The hilum is where all the blood vessels and nerves come in and out. Okay. It looks like a kidney bean. I guess that's why they named them kidneys, because they had kidney beans, and they said, oh, look at that. It's just like this thing inside the guy's body here, so we'll call it a kidney. The coverings of it, remember that most of your organs, in fact probably all of your organs, are surrounded by a covering called the fascia. In this case we also call it, well, this is important to know because when we're talking about cancer and whether it's escaped out of the capsule or the fascia that surrounds it, but this is what literally supports the kidney and holds it to the abdominal wall. If you don't have this, or if it's not inserted properly, then that's when you get nephrotosis. So that's when the kidneys drop down into the pelvis every time you stand up. The adipose tissue, so on an x-ray of the abdomen, the reason why we're able to see the kidneys is because they're surrounded by fat. So the fat protects them and, like I say, cushions the kidneys.
Is the renal fascia the giratus fascia?
Yeah.
Okay.
Yeah. And that's very important because, as I said, if you have cancer in the kidney, if it escapes out through the giratus fascia, then that's now treated as a whole different type of cancer. You know, if it's just inside the capsule and inside the fascia, you cut out the kidney, you're probably going to be okay. But if it's escaped, then now you're in deep pee-pee, I guess, not poo-poo. Oh, see how he adjusts to that? Okay, let's see what else we got here. Okay, so this is again, you're going to be we're going to be looking at different aspects of the kidney, but remember that we have three types of imaging agents. Actually, we've got functional agents, which are your DTPA and MAG3. And then we have what they call morphology agents, which are DMSA and glucoheptanate. I don't even know if they make glucoheptanate anymore.
Use it anymore.
Yeah. Then we also have protectatate, which we use for like scrotal imaging or just renal cisternograms. Okay. But anyway, let's take a look at the kidney. So remember, the outside part is the cortex. The inner part is the medulla, and that's where all your collecting system is. The tubules form this thing called the renal pyramid. And then separating the pyramids, you have the renal column. I'm not really concerned that you memorize that. But the pyramids, you should know what they are. And they drain into what they call the minor calyces. These calyces are actually very muscular. And they actually have like a peristalsis. So they actually squeeze the urine. Whoops. They squeeze the urine into the major calyx. And then from the major calyx it goes into the renal pelvis. And then from the renal pelvis it goes down the ureter into the bladder. Okay. And then this thing here, the renal papilla, those are just the little openings at the end of the pyramid that drain into the minor calyces. This area where your ureter comes in and the renal artery and the renal vein come in and out, that's called the hilum. So we know that the lung has a hilum, we know that the kidneys have a hilum. So when you have like this indentation where blood vessels, nerves, and stuff come in and out, then that's usually what the hilum is. Okay? So far so good. Y'all remember this from your anatomy and physiology? Okay. And like we said, the cortex contains the glomeruli, and then the collecting system and everything is normally in the renal pyramids.
So you said there's two types of radiopharmaceuticals you use to image.
Yeah, we have the functional agents and we have the, I would call them morphologic agents.
That was just the
Well, glucoheptanate is also still considered a, you know, we remember we talked about the kidneys retaining glucose. And glucoheptanate was actually kind of like a glucose-based radiopharmaceutical. It's basically like magnesium and sugar. And so what happened was the kidneys would retain it. I mean, they would still excrete it, but it would retain enough of it to where you could do morphologic imaging with it.
Where does it get fixed in?
Well, it just basically gets trapped in the tubules. Some of it gets excreted out, but it's not excreted out at a very fast rate. And that's why it was good for that. In my day, we used to only use it for like a renal flow study. If we were just looking at blood vessels, we would use it for that. And then we may do it for morphologic studies where we're trying to evaluate, you know, kids that had glomerulonephritis or pyelonephritis, things like that. You know, basically we're looking for something where pathology was distorting the shape of the kidney or had damaged areas of the kidney. Glomerulonephritis is one of the big ones that we, you know, when you guys do a DMSA study, you're typically dealing with a kid that's had a lot of, it's not really an infection. Glomerulonephritis is actually one of your autoimmune disorders. You know, what happens is you've got bacteria up in your throat, you know, the streptococcus, you know, beta hemolytic strep, and it produces a toxin called streptolysin. Streptolysin literally dissolves red blood cells. And in fact, we use it therapeutically, or at least I don't know if they still do, but if you're having a heart attack or if you're having like an embolization somewhere, they inject streptolysin and that actually dissolves the clot. So a person who's having a heart attack, they'll be injecting streptolysin to dissolve it. Okay? At least I think they still do it, I don't know. But the problem is that the streptolysin causes your body to form antibodies against it. And if you have repeated exposures, eventually that sets up what they call an autoimmune disorder. So that's why, you know, your own body will then start attacking cartilage. You know, the cartilage in your heart, you get rheumatic heart disease, you get rheumatic fever, you get rheumatoid arthritis, that type of stuff. And you also get, it affects your kidneys. The antigen-antibody reaction forms a complex that we call PANUS, P-A-N-U-S, and that stuff is very, very irritating. That's what forms in the joints to create rheumatoid arthritis. That's what deposits in your kidneys for glomerulonephritis. And when that happens, it can be fatal. You know, between the two types of inflammatory diseases of the kidneys, they're both pretty bad because the glomerulonephritis over time will scar the tissue, and then you basically wind up losing renal function. But pyelonephritis can be more devastating because it's an acute infection, and you can get septicemia from it. And, in children, both of these things can be potentially fatal if they're not treated. So, but anyway, so let me think what else we have there that's important. And the thing is that the way that our renal imaging agents work is very important. That's why I was saying, this glomerular filtration rate is treated differently than what we call the tubular secretion, or what we call the effective renal plasma flow. Okay. This is just another example of what it looks like. Okay, you have the glomerulus up in the cortex, and then here's your proximal collecting tubule, and then here's the loop of Henle down here in the medulla. Comes back up into the distal convoluted tubule, and then it goes into the main collecting tubule or collecting duct. Okay. And then this goes down here where all these things come together. That's the renal papilla. I don't really care if you know the renal papilla or not, but you should know the collecting duct, and you should know the proximal loop of Henle and distal collecting tubule. Again, on your board examinations, they're going to ask you, okay, which part of the kidney, which part of the system would use simple diffusion, and that would be the proximal part. And then which part would use active transport, and that's going to be the distal part. What does antidiuretic hormone affect? The distal collecting tubule. This is where it's going to reabsorb more water. Okay.
What's that collecting about? Because I know that's for aldosterone.
Yeah, and then aldosterone would be for the collecting duct here.
So ADH is just the distal convoluted tubule?
Yeah, and that's just for the retention of water. And again, like I said, the reason why that's important is because a lot of times when we have patients that have renal problems, and they're dehydrated, they're going to be giving you false results as far as renal function. Why don't you guys take a short break for about 10 minutes?
ADH, that's the distal or distal?
The collecting duct, mainly, for the resorption of...
For ADH?
Yeah, ADH.
So it is the collecting duct? Because I know that's where the aquaporins are, and it's like...
I thought after that it's just...
Well, ADH, I want to say that it...
There's some simple diffusion in the descending loop of Henle too, right, where the water leaves?
Yeah. Well, what happens is we haven't talked about the peritubular blood vessels, but that's where...
The vasorecta.
Yeah. And so what will happen is that when we get to that, you'll kind of put it more in perspective as far as...
It's a little complicated when I first learned.
Yeah.
There's these little blood vessels.
Okay. So why don't you go grab a quick break.